Hello and welcome to another Applied Radiology Expert Forum webinar. Today's program is entitled Increasing MR Operational Efficiency with 3T, and we'll be discussing the operational impact of upgrading to a 3T scanner. Over the course of the next hour, we'll share excerpts from interviews that I conducted with Franco Grippo and Kris Giordano from RWJ Barnabas Health Ambulatory Care Center in Livingston, New Jersey. We'll also share some additional information that we'll highlight on how they are addressing the backlog of MR procedures as a result of the COVID pandemic. Mr. Grippo, do we have you on the line today?
Yes, hello Kieran, hello everybody. Pleasure to be here and thank you for the opportunity to tell our story.
Thank you again for joining, Franco. Mr. Giordano, how about yourself? Do we have you on the line?
Yes, Kieran, and again, thank you for having us. We appreciate the time, and good afternoon, everyone.
Fantastic. Thank you both for joining. I'm Kieran Anderson, Group Publisher here at Applied Radiology. I'll be your host and moderator today. Today's program has been sponsored by Philips, and we would, of course, like to thank them for their continued support of events such as this. As a reminder, information presented here today is that of the speakers, and any findings, data provided are based on work at their own institution and may not be reflective of other installations and our Philips healthcare policy and compliance. Following the formal portion of the program, we'll have time for a brief Q&A, so please stick around for that. And before we get started, let me quickly run through some quick tips here that'll help you view the program a little better. So currently you should be seeing a screen that looks like this. If you'd like to expand the viewing area, please select one of these options in the top right corner. Here on the right, we have our resource area with several links and a case study that you can download. Down here on the bottom right, you can enter any questions that you have at any time for the panel to consider. Click Submit and we'll see them. And finally, at the bottom is our control panel, which allows you to toggle these windows in and out of view for enhanced viewing. Before we start the program, I'd like to run the first of two quick polls for you. Hopefully you'll participate. This first one here is pretty simple. Are you currently using a 3T scanner in your practice? Yes, no, no but considering an upgrade. I'll give you just a moment to participate in this poll. I'll share the results and then we'll talk more about these during the Q&A. Right now it looks like we've got quite a number that are already using 3T. That's great. So we're going to get into the program here. Thank you for sharing that input. We're going to now play a pre-recorded video that's going to run for approximately 40 minutes. If for any reason the video pauses or stops, just please refresh your browser. Unfortunately, we do not have control over your internet connection and/or your available bandwidth, which dictates the quality of your online experience here with us today. You may also need to adjust your volume as well. So without further ado, thank you for joining. We'll start the program. First, we are going to hear from Franco Grippo, Assistant Vice President of Operations. Franco is going to share details related to their recent upgrade to a 3T MR scanner. He'll also speak about the associated increases in both their productivity and operational revenues. Welcome, Franco.
Hey, thank you, Kieran.
So, Franco, maybe you could tell us a little bit about your facility, the MR department, what kind of patients you're seeing there on a regular basis, what your institution is known for in your market here in New Jersey.
Sure, Kieran. So we're a very large comprehensive outpatient imaging center, inclusive of MRI, CT, nuclear medicine, PET CT, ultrasound, X-ray, as well as a very large breast center. We perform close to 150,000 procedures annually, making us one of the largest freestanding imaging centers on the East Coast, if not the nation. And our MRI department is really a center point for our imaging department. We have 4 MRI including two 1.5 Tesla magnets, an open, and of course our newly upgraded 3T. We have about 35 radiologists who are all board certified and with specialty certifications in almost everything, including neuroradiology, MSK, and breast. We perform a wide variety of patients, including breast, MSK, but really our neuroimaging is what we strive and do well at.
So I understand that there was a community need for a 3T scanner upgrade at your facility. How did you determine that you needed this?
Yeah, so I believe in healthcare. Our job is to ensure we meet the needs of our community. So when we were looking at upgrading equipment, we tried to really look at the overall landscape. We evaluated utilization by machine. We looked at referral patterns and referring physicians that we serviced to ensure that we were making the right choice. So when we looked at utilization and noticed our 3T was 100% utilized over the last 4 years. So we knew that the volume was being shifted to our 3T. Speaking to our community physicians, they more and more were requesting imaging on 3T only. In addition to that, we have one of the largest MS practices, if not the largest MS practice in New Jersey, that was just ramping up and being restructured. And we knew that we needed to support their growth with imaging of 3T. They require a high level of imaging, and all their patients needed to be scanned on a 3T magnet. So we knew that we needed to support their growth, which is why 3T upgrade made sense for us. So next step was building our business plan.
So tell me a little bit about how you went about preparing your business plan to justify this upgrade. What was the process? How long did it take? Who was involved?
So first part of the process was evaluating our community needs, which I believe is the foundation for any financial success. When we looked into the 3T and what best would suit our needs, it was clear that the Philips solution was the right choice for us. The compressed sense and the upgraded hardware allowed us to increase efficiency, which led to increased throughput and ultimately increased capacity. So in order to be approved for a project, we had to ensure that the investment would not only meet the needs of the community, but would also provide a good return for the system. So we leveraged Philips' superior compressed sense software, as well as their multiple superior hardware upgrades that are available on the Elysian. And what we were able to do is project that we can reduce scan times by up to 50% with no effect on image quality. So to us, that meant increasing 3T capacity by 25.4% or an additional 1,000 plus studies annually. And when we incorporate that payer mix, that comes out to a little bit over $500,000 to our bottom line. But even with such a solid business plan, the entire process took over 2 years. And it was comprehensive. It involved frontline staff, management, working hand in hand with Philips, and ultimately our chief financial officer and final approval from our CEO. So we installed our project installed our 3T Elysian in 2018. And here's some pictures from the great day. So after that comes the hard part. That is making sure that our projections or our business plan comes to fruition. What we did was we did a retrospective study after 1 year of service to see if what our projections were in our business plan came true.
Given the new advanced MR scanner technologies that exist and that particularly Philips is providing on these new scanners, have you appreciated any of these workflow improvements in your MRI department?
Yeah, just, when it comes to formulating a business plan, that's one thing, but seeing that business plan come to fruition is really the important part of the whole process. And what we found was not only did we meet expectations, but we far surpassed our expectations. And when we built our business plan, we projected an increase of 25% or 1,000 plus studies, and bringing over $500,000 direct to our bottom line. But that looks great on paper. The proof is in the pudding. So with us looking at it a year later, we found that not only did we meet, but we surpassed our expectations and increased 28% in almost 1,200 studies, bringing in $814,000, 291,000 over projected, and that's if you calculate out, that's 55% over projected. So significant improvement even over our very aggressive projections. And when we looked at it year to year, we were prior to installation, we were seeing a slight decrease in bottom line profits because volumes were sort of slipping because we pretty much reached our capacity of throughput. So by increasing the throughput and efficiencies, we were able to swing that delta from 2018 or 2017 through end of 2019 over $1 million.
What else would you say about the whole experience working with Philips, and I guess in this case particularly their MR team, from sales to customer service, apps and training?
Sure. I mean, honestly, I've dealt with a lot of vendors across many modalities and felt that this process going through the installation of our 3T was one of the most collaborative efforts that we have been through. Philips was very supportive through us every step of the way, really making sure that they weren't selling us a piece of equipment, but more making sure that we got the right piece of equipment that fit into to our needs. So they felt like less like a vendor and more like a part of the team, and really invested in our success and our vision.
Now I have the pleasure of speaking with Kris Giordano, Director of Imaging. So Kris, can you tell us a little bit about yourself and how long you've been at RWJ Barnabas?
So I currently hold the title of Director of Imaging at RWJ Barnabas Health Ambulatory Care Center in Livingston, New Jersey. In my current role for less than a year, but been with the organization for 14 years now, and MR technologist by background. Worked in the industry and as an MR technologist since 1995, not to date myself.
Tell me a little bit about your facility, your MR department, what your institution is known for in your market.
Sure. So we are a facility that's a hospital-based outpatient facility, a high volume. We kind of term ourselves as an advanced imaging facility where we'll do things like spectroscopy and high-end breast work. We work in correlation with our breast center upstairs. And on the modality of MR specifically, we have a 4-magnet facility. And the goal of having multiple systems is to be able to accommodate any patient need or any patient type, whether it be a bariatric patient that has problems fitting in the traditional system, or moving towards a wide bore digital 1.5 Tesla magnet that can accommodate everything from high-end breast imaging and breast interventional work, in addition to things like prostate work and really high-end throughput. And then our most recent addition to our fleet of MR systems is our new 3T Elysian, about a year old. And this system is really giving us the ability to do everything, where we can do high-end MS, we can fuse and really work in conjunction with radiation oncology, and we have a ton of neuro applications, but then still be able to do diagnostic breast imaging and really do a ton of just tremendous consistent work on a day in and day out basis.
Tell me a little bit about your patient population.
We have a patient mix of, we do have a lot of tremendous amount of oncology and cancer work in addition to MS. But we also have a neurology mix and epilepsy base. We have a ton of referrals from body work like radiation oncology and a ton of liver work. So we have a patient mix, a demographic mix that isn't really geared towards any one specific target. We'll do our fair share of pediatric work, even though we're not a primary pediatric center. We have a bariatric feeder upstairs where there's bariatric surgery, so we get a lot of work from them as well. Tremendous, obviously, orthopedic percentage to our mix, but I think primarily we do a lot of work in the realm, in the arena of neuro.
Okay. Back to the scanner, the Philips Ingenia Deletion 3.0 Tesla that you mentioned, which from what I understand delivers pretty superb image quality, performs exams up to 50 times faster. Does your system have some of the advanced features? Have you had a chance to play around with any of those features?
We've had ample opportunity, Karen, and the interesting part is we did not predict the system as well as we could have, and I'll explain what I mean by that. Our initial goal with the system was to compensate for backlogs and appointment bookings for MS and for neuro and things of that nature, and still correlate with RADONC for staging protocols and sequencing, therapeutic and things of that nature, where we saw that tremendous growth in the oncology arena from the referral base, and we really wanted to meet that demand with a system that we knew was going to be reliable and consistent. What we didn't expect with this current system was the benefit, the homogeneity, even at 3 Tesla, where body work is so stellar and the consistency is so stellar, and the time savings was in such a manner that we started seeing that doctors were now asking for this 3T system that never were, liver oncologists and whatnot. And so we started to look at what was the reason behind that. And it's not even twofold, it's more 3 or 4 pronged as to the means or the mechanism behind such a demand for the system, so much so that our future considerations are looking to add an additional 3 Tesla to our department. Thanks, Karen, and I appreciate the opportunity to, again, just kind of talk about how Barnabas has really benefited from the system and installing the system about 18 months ago. So this system and the Elysian X has really been one of those systems where that speed that's really so vital for us, and especially in current light of COVID-19 and really departmental throughput, we really look at this system as being advantageous, especially from the option that we looked at called compressed sense. Compressed sense really being that almost novel case-based filling technique where we can yield speed really without a resolution penalty. MR and working in the modality of MR for such a bit of time, there's always been that give and take or nothing for free mentality. To have an option on the system that yields speed and doesn't sacrifice resolution, you question the validity of that, but implementation, and you see how consistently reliable it is. It's been an absolute game changer for us. One of the options that really is at the discretion of the radiologist is the denoising filter. Whether we implement a weak denoising, so a healthy amount of noise remains, that helps us to kind of retain resolution. Or if we apply a strong denoising filter, that gives us the ability to remove some of the grain in the image and smooths out the image quality. We think of that in older days of a filtering option, a filtering post-processing consideration So there's options in how to really apply the compressed sense. We look at compressed sense as best suited for high contrast sequences, especially MRA or MRCP, or T1 weighted sequences, where we really have that super bright fat, that really dark fluid, and you're comparing those two tissue contrasts as a stark high contrast tissue contrast mentality. And compressed sense is really best suited for those techniques. I'll give you the references at the end of the slides, but Philips has this comparison where conventional imaging and essentially filling all of K-space row by row and essentially a time penalty where it's a slower acquisition. We're able to get the edges of K-space, so we have sharp resolution. We're able to sample the center of K-space, so we have better signal. Now the non-sense compressed sense method, where it's faster, but we lose that whole detail aspect on outer edges, and then using Philips compressed sense. I kind of think of, if you ever watch YouTube videos and how they make the granite countertops and they have those flakes in them and they kind of sprinkle them on the counter before it seals and then enamel seals. I kind of think of that as the methodology behind filling K-space, where there's almost a randomization, but that randomization creates a balancing where we're able to acquire the necessary speed in filling or spending less time filling K-space, but we're able to still maintain that signal and that detail that we so crave when it comes to that speed factor. So in our practice, we've taken a 22-minute contrast enhanced MRA of the carotids on our older 3T system, and we were looking at a 2D and 3D time of flight as 8 and 9 minutes respectively. We know that 8 and 9 minutes is challenging when it comes to a patient compliance standpoint. So now we take that aspect and we turn it into adding compressed sense to our practice with the 3T lesion. Our total exam time has now been translated to a 10-minute exam time. Again, as I said, the 2D time of flight, 4 minutes, 3D time of flight, 57 seconds. Well, 57 seconds may sound like it's almost too fast, and sure, there's a tad bit of noise in the image, but it's diagnostic. It's patient compliant. And again, when we talk in terms of decompressing our department and reducing foot traffic, maintaining that social distancing and decompressing our waiting rooms, we really accomplish that by the utilization of compressed sense. For us at 1.5 Tesla and 3T, but especially on this 3T system, where that novel case-based filling lends to examples like this. Respiratory triggered 3D MRCP on our old system, 4 minutes. 4 minutes, that's respiratory triggered, and that shallow breather could essentially be 6 or 7 minutes of acquisition time. Now we translate that 6 or 7 minutes into a minute and a half, maybe a minute 40 tops, because the acquisition time, especially in that high tissue contrast MRCP 3D application, even though it's respiratory triggered, it yields us that success factor where we're able to accomplish our exam time and our acquisition in a much faster time period, increasing our patient compliance. A foot MRI, plantar fascia protocol. We look at plantar fascia, we see that on the script, and we know that that's one of our typical monthograms where we have to cover so much anatomic ground, and we have to really get from the heel to the ball of the foot. We have to get such a large range of coverage, but still maintain that detail at 3 thickness. We're talking our coronal obliques or transverse cuts through the foot can amount to anywhere from 40 to 44, upwards of 48 slices, and that could be challenging from the time perspective. 37, almost a 40-minute scan time on our previous system. Applying compressed sense, 6 sequence exam time, we're looking at a 14-minute total exam time for a foot MRI for a plantar fascia protocol. I think we're using 12 minutes for an ankle. We're also using a time saver of the Dixon fat separation turbo spin echo base to reduce imaging time. A great method that we can really look at our potential for how we can accelerate our scan time in a wide range of clinical applications, whether it's simple orthopedics like foot or a knee, or getting into body work where it can be challenging with respiratory triggering and breath holding, and how can we achieve that compliance so well. We also look at comfort as being, again, one of those challenges when it comes to MR. MR, that modality where scan times can be lengthier, patient comfort typically would be challenging. So on the 3T lesion, there's memory foam padding, stellar patient feedback, especially for the lumbar spine and disc herniation, or the cancer patient and the multiple myeloma patient, where it's a more comfortable table for them to lay on. Speaking of the table, it's a concave table, so we have definitely achieved a reduction in exam cancellations due to claustrophobia. Using D-string technology, that's improving our signal. So even with the extra padding or the concave table, we're able to achieve a wide range of coverage, especially in the head to foot direction. And that D-string elements that are built into the table, we almost think of it as that MR Bucky, if you will, not to go old school. And that method of how we can improve signal based on elements built into the table and not adding a separate dedicated spine coil, reducing in-bore room for the patient, that allows us to image a bariatric patient or the claustrophobic patient, even feet first for a thoracic spine MRI or CyberKnife prostate MR, where we're able to achieve, again, that consistency and that patient comfort that we so long strive for. Sometimes we even look at that system as an alternative for our open MRI, because we know that we can talk a patient into a 12-minute exam using a little faster technique and a fast brain protocol of a 7-minute study, a 6-minute study. Are we able to convince the patient based on the speed that we can offer them and not have to compromise resolution? Other comfort features that improve our compliance on the system are auto voice options. Over 30 languages, improved completions, and better breath hold compliance really enables us to have that methodology of assurance that no matter what the challenge is, we're able to meet that challenge. We love the option of being able to elevate the base of the head coil to match that kyphotic patient. And as we elevate the base of that coil, we're essentially raising the signal, the much needed signal with the patient. So there's not that loss of signal due to distance. We're able to match the patient's challenges and needs and not sacrifice image quality. Utilization of mirrors for the majority of exam anatomy is definitely a helpful tool in, again, achieving that claustrophobic loss reduction. And then motion correction software. We love the feature of Multivane XD. We're able to fill case space in a radial fashion, and the XD option of Multivane or other vendors' motion correction case space filling, the XD option adds the parallel imaging feature or speed acceleration. So I can correct for motion while being able to still get affordable scan times and in multiple body parts, head, shoulder, lumbar, knee, doesn't matter. And now we're not prone to, whether it's gross patient motion or simply popliteal artery motion, flow motion artifact. We can eliminate that altogether by not being so reliant on phase direction limitations. Now we're able to automatically mitigate that by having that standardization. So the patient comfort aspect is one of the hugest advantages of this system, where we see such tremendous compliance, we see such tremendous outcomes when it comes to the patient's response to us and the patient's response on their satisfaction surveys as they're walking out the door, as they get that email that day or the next. One of the other systems, or one of the other advantages of this system, Karen, is the consistency. And we really look at the option for how is the system going to deliver From the perspective of totality, how is the system going to deliver from the aspect of achieving reliable, consistent, reproducible outcomes? Smart Exam is one of those features, especially from the brain imaging standardization, consistent angulations, MS and consistent follow-ups, cancer patients, treatment, efficacy. These are all huge diagnostic wins from the perspective of the reliability from that clinician and ordering these exams and delivering on these exams and knowing that he or she is going to have a similar outcome in spite of maybe tech levels of experience or training and different methodology behind that training. Spine imaging is consistent, breast imaging reproducibility, and how we can consistently deliver on like planning and like angulations. And that is how we're able to deliver a consistent product across all of our procedures and protocols on the scanner. The VitalEye feature for respiratory triggering, how it reads that rise and fall on the patient's torso and that laser detection, where now we eliminate that inconsistency in our technologist positioning variations. It helps to improve the accuracy in our treatment planning for staging, whether it's staging pelvic cancer, and we can look at whether or not that treatment is working. Prostate MR, huge growth potential in our metrics as we evaluate our volumes due to consistent results. CyberKnife prostate, all on 3T, consistent imaging. We're able to use the 3D pelvic exam and the 3D oncological features on the system so that we can have completely isotropic imaging. We can have consistent, reproducible image quality, regardless of the patient challenges, whether they be breathing, or claustrophobia, bariatric patients. We're able to accomplish consistent imaging throughout. Some of the features from this system that we find to be so paramount, especially in today's era of such a myriad amount of implants, limitations of patient safety. ScanWise has become one of those features that we could not purchase a system or look at a system from this day forward without having this feature. It's that vital to not only our practice, but to enable protection from a safety aspect of both patient and staff, managing MR conditional implants while still being able to utilize 3T, giving us that superior signal and resolution potential. We know there's going to be a drawback to this as we set those parameters, those limitations, whether it's Gauss per centimeter, whether it's in watts per kilogram, microtesla, B1 and RMS, whatever that limitation is of that MR conditional implant, we know that the system will create the calculations necessary based on the patient's demographics and implant restrictions, and we know that there will be a lengthening of scan times relative to SAR or normal mode implant restrictions. We also appreciate the feature that the SED rate calculations will total examinations within the data service. But now we have that totality of SAR multiplied by the number of exams in a patient day. All of these methods that we can ensure that the patient is being kept safe while under our care in spite of whatever that implant is. I love the fact that it's very user-friendly, the ScanWise options. You're entering field strength, you're entering the spatial gradient, the RF limitations. You're setting those at the registration page. The system will then give you the calculations or will give you the limitations of where an implant should or should not touch or what those limitations are. And then we can really appreciate the fact that it comes right up on our system that we have everything in front of us. We have a screen capture that we can take, that we can send back to PACS, that we have that forever record of here it is, here's the patient's limitations. We stayed within those restrictions, to keep the patient safe, regardless of what that limitation is, regardless of what that restriction is, that we're able to maintain their safety throughout. And then on the last important aspect for us is implementation. We can purchase great software. We can add wonderful features that were just paramount to the potential for what we could do on the system. But implementation and really bridging that gap between having, let's say, per diem technologists that work on other vendor systems and translating that language into what they see on the scanner. We have a technologist that we're training now, and she's up to speed and she's up and running for us. Experience on another vendor, it looks overwhelming, it looks daunting because there's so much in front of you, right, parameter-wise, yet here's that magical F1 key. You have everything right in front of you. Training through online portals, whether it's the net forum where I can go download an exam card, or through on-site applications. Philips headquarter training, going out there to learn the specifics and get on the scanners, hands-on. Cardiac MR, we've sent a number of technologists to, and they've come back more proficient and more ready to image patients. Advanced applications and features of the system that maybe we didn't pick up on the on-site training. And then helplines, literally just a phone call away, literally on first name basis with some of these individuals who have helped us tremendously in tweaking our protocols and implementing these so necessary aspects of getting our protocols to be the best that we can possibly get them. Having these screens on both sides is easy for us to see the triggering, to see the waveform on a cardiac patient. Having the ability to control everything on either side of the table, to see the waveform that we need, to have that nice wide opening, really are all of those features and options that make the system so, for lack of a better term, inviting, make the system so consistently reliable in our practice, and have really worked towards improving our productivity. References for both the ScanWise and for the compress sense, and ways that you can really say that those would be advantageous for you. I do appreciate the time and the ability to just share a few things and how this has been so advantageous for us. Thank you.
Kris, final question for you. Since you've installed your new 3T, we've all been dealing with the COVID pandemic. Please share a little bit about how you've worked through this process and how you are managing patients in your facility during this time.
So this COVID has changed everything for everyone, and there's no mistaking that it has touched all aspects, all levels, all careers, everyone. So how do we as a healthcare provider really manage that as best we can, right? Yes, we're getting information from multiple sources and trying to collate and correlate that to our practice. There's a few things that have gone on previously and are continuing to go on as far as today's discussions, and all of this to prepare for a better tomorrow. But please understand me 100%. This better tomorrow has nothing to do with financials. This better tomorrow is going to be safer for the next while, that I don't know when that's going to be. So there's a few aspects to it. First and foremost, the cleaning of the equipment. So we're in an only elective mandate, a non-elective mandate, right? It has to be urgent or we shouldn't be scanning. So we screen everybody coming in, and that screening entry into the building will not stop if some of these restrictions are limited, because we still want to control, especially those that may be COVID positive. So we have a triaging and a directing into an isolation or a staging room. Especially we see, and really I have such respect for all modalities in our line of work. So those x-ray techs that are going to get those chest x-rays and those CT techs that are going to pick up those CAT scans of the chest, they're gearing up, they're going up, and what we're doing to eliminate and reduce the foot traffic is performing an expedited registration. So we know what patient, we know what their demographics are in the prescription, and we're going to have our technologist staff bring that registration paperwork with them so we can expedite the intake and avoid that patient that's potentially or is positive from landing in that imaging waiting room. We bring them directly to the treatment room, while housekeeping, who's right behind us, and environmental services has been unreal in what they've done. They're coming behind us and they're disinfecting rooms and disinfecting every touch. We get to the room, we image, we expedite and walk and escort the patient out of the building. But now what do we do when we're looking at MR, where the patient's been in the magnet for a longer period of time? So we have the wand and the disinfectant bleach wipes on the end of that wand that we're using for a complete wiping down and a dry time inside that room. There is a wait time after that procedure is done. Today especially was a little bit of a sad day in our building where we removed half the chairs in our waiting rooms so that we can encourage, promote, and force social distancing. Every patient, so we're looking at supplies on a daily basis as to what we have in-house and also our PPE run rate. So per modality, how many supplies are being used, in what departments, what modalities, so we can ensure that we have enough to manage the population that's coming in. The problem we're running into is the backlog of screening mammograms, bone density exams, those typically elective procedures, calcium scoring. They're not emergent, so we really can't be booking them, and we want to be safe about that. So I'm not going to run any numbers on productivity for our 4 magnets, right? We're doing a staggered spacing. So yes, we have the capability for 15-minute time exams, but with dry times and patient on-off and in between infection control practices that are our new norm, we staggered 2 of our pieces of equipment to start at 7 in the morning and have hour time slots. 2 of our magnets starting at 7:30 in the morning with hour time slots, so that we can have 2 people coming in at 7, 2 patients coming in at 7:30, and we hope we can maintain that elimination and reduction of simultaneous foot traffic. Same model in CAT scan, same model in nuclear medicine, so that we can stagger out and again, we're used to being a high volume outpatient imaging center where everything is go, 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 go. I hate to say it like this, but COVID says no, 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 right? Where you have to look at that with a different set of eyes where we can't act, behave, schedule, plan, think the same way. Now we need to look at our model as how are we going to ensure, not guess, we have to ensure that we're going to reduce the amount of traffic coming in at certain times. Now, unfortunately, that's going to mean longer hours, and that's going to mean more days of operation, and we may not have had tremendous Sunday hours in the past and things like that. That new model looks like we're in phase 2, going to have to open up long and late hours on Sundays. But on the flip side, those that have been covering in command centers and helping out anywhere that there's been help, I've had people that are 15-year, 20-year, 30-year veterans of mammo and ultrasound and technologists that are well-versed in their modality. I've had them parked at entrances to the building, simply screening patients coming in, asking the appropriate questions. I have been unbelievably awed at the outpouring of anybody willing to jump in and do whatever's needed to be done. I have never been more impressed with, I've always loved healthcare, I've always loved imaging. I have never been more impressed with healthcare and all those everybody, delivery men and guests, attendants, you name it. how everybody has jumped in to whatever needs to be done. We're going to have to extend out some hours, or we're going to have to look at our hours of operation and foot traffic and screening patients so that we can really reduce, eliminate, and not be any way, shape, or form a contributor towards any infection spread.
Well, gentlemen, thank you for sharing your experiences here today with our online audience on how your recent 3T upgrade went and has literally changed the way you are doing MRI in your facility. I'd now like to open up the floor for questions from the audience, and a few have already come in, which we'll begin with. But let me remind those of you who may still have a question on your mind, feel free to submit it through the Q&A area, and we'll get to as many as possible in the allotted time for today's event. So with that said, Franco, Christian, I'm going to pose this first one for you, Kris, and we'll take it from there. So do you scan pacemakers or other conditional implants at your facility? And if so, how can you scan for treatment planning with a concave table? Do you use a table adapter or what? Can you address that, Kris?
Sure, Kieran. So two-part question. I'll start with the treatment planning. So particularly for CyberKnife, we use I want to call it the double thickness, but the memory foam padding that's inherent to the Elysian X system. And we set up with our physicist the exact match of planning to coincide with the CT simulation, and we've had tremendous accuracy with the treatment planning in that setup. So it is a concave table, but that padding kind of, I don't want to say squares it out, but it gives us the ability to have that exact match simulating or kind of coinciding with what is the CT simulation done the same day. Second question about the pacemakers, we do scan MR conditional pacemakers, and again, as long as the manufacturer has the clearance at 3T or has the clearance for what the conditions that need to be met, the simplest aspect to that is entering those factors into the ScanWise at the point of registration, as I said earlier. That really enables us to kind of have that total confidence that no matter what we said or what the radiologist plans for us protocol-wise, we don't exceed the safety parameters or almost the speed limit, if you will, of what that particular pacemaker or device has set forth by the manufacturer. So it really takes a lot of the parameter guesswork out of it, whether it's a SAR limitation, a Gauss per centimeter limitation, or a B1 RMS microtesla limit. We're able to facilitate that limit safely and really give the confidence to the technologist and the radiologist that we can deliver. Good question.
Kris, as a quick follow-up to that, does the ScanWise feature cut down on the necessary communication that you might typically have, say, between the technologist, the radiologist? Can the tech essentially proceed without waiting for an approval to scan, obviously saving more time? Have you found that to be the case?
We have found that to be the case as long as, and I want to give a little asterisk caveat to that, as long as our system works as intended. So if the scheduling coordinator is indeed getting that implant at the time of the appointment and delivering that into the scheduling work list, that our technical staff can obtain that documentation, then yes, we can easily facilitate that. We have our set base of protocols that are already set up for us, where the radiologist would not need to, in a sense, okay each particular limitation that we're setting. We scan in the documentation into PACS on what that particular MR conditional implant is. We actually screenshot the ScanWise entry so that we know we have that forever legal record of what we did to ensure patient safety. So short answer to your question, yes, it does help to expedite that intake for that patient.
Thanks for addressing that, Kris. Franco, this one's for you. And first, amazing accomplishment with regard to the profitability with the upgrade, and I'm sure everybody's pretty happy about that. Are you predicting that you will max out on the 3T patient volumes? And, you know, what was the impact on patient volumes on your 1.5 scanners? I'll start with that, and we'll follow up from there.
Yeah, so thank you, Karen. Do I predict that we will max out on the 3T? Obviously, that'll depend on need. I mean, I can say that utilization has continued to increase, but with that, we have also expanded services, opened up Sundays, and really Kris and his team has tweaked the system to improve the efficiencies even more, so reduce scan times even more, and things of that nature. So for the utilization, I think will continue to increase, but there's options on our end. We can expand capacity to meet the needs. As far as our 1.5 systems, the utilizations have pretty much stayed consistent, if not slight decrease. With the downside to having a really good system is that word travels fast, and we're seeing a lot more referring physicians, like Kris had mentioned in his talk, now shifting more towards that 3T and requiring that 3T on their patients. So we work well with the referring physicians to let them know that certain patients may benefit significantly on the 3T because of the image quality and the throughput, and others not so much. So we do work well with them to make sure that we put their patients on the best systems.
Right. Appreciate that as well. And what about the impact of COVID? Just, quickly, if you could comment on, say, the backlog that you mentioned of studies. What impact is this having on the business that you're managing?
Yeah, COVID has changed the world, and we're not immune to that by any means. So it kind of throughput and efficiencies almost takes a backseat when it comes to this, because regardless of how quick and good the image quality is, we still have to adhere to the social distancing and the safety of our patients. So we have a very detailed plan. Kris sort of touched on some of the initiatives that we put in place, but we sort of tackled it from every angle. PPE, we focus on that, ensuring that we have the quantity that we need here to continue to grow. We scatter scheduling, so where we have all machines going at 7 a.m., let's just say, we're scattering them where we have 2 going at 7, the next 2 going at 7:15 or 7:30. Just reduce the number of people in the waiting area, and we have to build in time to sanitize the machine after every patient. So we're just now entering our phase 2. I think we're pretty aggressive but very cautious when it comes to opening up. And some of the things that Kris touched on is right on. The efficiency of the machine at some level is important because it can reduce the amount of people in the waiting area and in the common areas, and we leverage that as well. So the backlog of patients was huge, and we're just starting to tackle them now, doing it responsibly, and with that comes expanded days and scan times later, Saturdays and so on, but we have to make sure that do it safe for our patients. Exactly what.
Thanks for that, Franco. When you speak about the scheduling and the staggering that both you and Kris talked about there, and how did that affect the staff as well? And, also scheduling, and did you load this all into your schedule, or was it a manual process? I mean, a lot of this you're kind of doing on the fly. Maybe you could comment on that.
Yeah, so we're learning as we go, kind of way. So we do have a pretty robust scheduling system. So we built our templates in to make sure that we're staggering the scan times, but we also don't know how effective that is unless we're physically out there. So myself, Kris, the staff, we're rounding many times a day, making sure that the waiting rooms aren't too full, that our plan is effective, that if we're saying in our phase 2 that we're anticipating 60% of normal volume, that's actually happening, that the sanitation processes that we put in place are actually happening. So there is definitely a manual process and a more visual process, but then we do also leverage our technology and build templates in our scheduling system to ensure that mistakes are happening, and we also have to be cognizant of our add-ons as practices open up and stat procedures are requested. We have to make sure that we build some leverage in our schedule to compensate for these stat procedures, and that's what we do. We build in about 3 hours of time just allotted for stat procedures.
Franco, when you were working and worked the staff with Kris and all of your colleagues there, and making the strategic decision to upgrade, how much influence did the radiologists have on the process as well?
Significant. So from a clinical standpoint, they were in lockstep with us. We vetted every vendor that was out there. We looked at images. We went on site visits, looked at everything, and based on what they saw and the image quality and type of studies that we were doing, the breast studies, the neuro studies, that kind of thing, they were hand in hand with us to make sure that we chose the right system for our needs, both from an efficiency standpoint, but most importantly from a clinical standpoint.
Right. Kris, coming back to your staggered bookings, I know we've talked about this a couple times, but another question came in related to it. Does it apply to all the magnets in your facility?
It applies to all the magnets in the facility, but a little differently. For example, we've had a wonderful open magnet right in the center of our department for 15 years now that served us very well, but it's a 1 Tesla high field open. I leave that appointment time at 1 full hour in our current state. We've been able to reduce in our current phase our 3T appointment times, even though the system is so fast and so reliable and so consistent across all anatomies. We're now getting to a 45-minute appointment time on both of our digital magnets, our 1.5 Ingenia, our 3T Elysian X. And that's giving us ample time to scan accordingly and still have the infection control processes in place, including spraying down even the lockers in the changing room in front of the patient prior to their entry into that room. If this is our, kind of new norm, we need to look at that as we started off with hours across all the machines. We've now adjusted that to our 2 fastest machines, now have incorporated 45-minute appointment times, and we're still able to maintain that. So, a short answer to your question, it does vary related to the speed of the equipment.
I guess a question for both of you. Would you consider a 3T as your only magnet at this stage, knowing what you now know?
I think if I had to answer that question 5 years ago, I would say no, due to implant limitations, due to homogeneity restrictions and challenges. With this current system, I would most definitely have a 3T as a primary solitary system in a practice, knowing all that it's able to do and only so very few implant restrictions like a vagus nerve stimulator or something along those lines.
Yes,
Right, right.
I agree. I agree with Kris. They're just so flexible now that you get everything you need out of that 3T.
Right, right. And Franco, final question. We're hitting the top of the hour here. You know, you spoke about the referral patterns and the changes that drove your reason to move and upgrade to the 3T, and you had also mentioned that quite a few of your physicians and referrers were asking for it, and as patients became aware of it. Maybe you can provide just a couple tips to those in the audience. And how did you market that to your referring physicians? I mean, they must have. You said word spread fast, but you must have done something.
Yes, Karen, absolutely. We utilize pretty much everything in our arsenal. So we already have a great relationship with a lot of the referral base. So word of mouth. We leveraged social media to communicate. We also have newsletters that we send out to patients, so we did some direct-to-patient marketing as well. So we really utilized everything in our arsenal to make sure we got the word out, to blast emails to our medical staff. We pretty much used everything to make sure that the community was aware of our new 3T.
Right. Well, I thank you for that sincerely, Kris, and really to both of you for taking the time to speak with us here today. It's really a pleasure. Franco, thanks again for taking the time.
Thank you. Appreciate it, and thank you everyone for attending.
And Kris, always a pleasure to work with you again too. Thank you, sir, for all that you did to make this happen today.
Thank you, and I actually just want to thank not only you and your team at Applied Radiology, but I also want to thank Philips for putting out an awesome piece of equipment that's really just been great, first and foremost for our patients. And then I do have to give a third thank you to Franco for putting together a great business approval and assigning the capital dollars that we could make this happen. So thank you all.
All right, gentlemen. Well, with that, I would like to again, thank all of those who had joined us today in the audience. We really appreciate you supporting these Applied Radiology Expert Forum webinars. And let me finally close with a special thank you to Philips for making this event possible through their continued sponsorship of events like this. So with that, the webinar has now concluded.